Hello, everyone, and welcome to today's industry webinar, Vendor Selection in the Platform Age of the EHR. My name is Ellen Knowles, and I'm the Marketing Communications Manager here at Azalea Health, and I will serve as your moderator for today's presentation. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Everyone on this call is listening in using their computer audio system by default. But if you prefer to join over the phone, just select telephone in the audio pane on the right-hand side of your screen, and the dial-in information will be displayed there. COVID-19 has made deficiencies and restrictions inherent to current EHR systems and more apparent and more intolerable than ever. Clinicians are really burning out faster and with more dire outcomes as the pandemic rages on. Even according to a research group at the University of New Mexico, 40% of physicians' burnout is attributed to poorly performing EHRs. So we're going to take a look at today's agenda. By the end of this session, attendees will be able to describe a framework for evaluating EHR platforms, list the differences between traditional EHR solutions and EHR platforms in the modern time, create a baseline list of qualifying questions, and then apply an EHR platform evaluation framework to their own vendor selection activities. Now I want to introduce our presenters today. We have Fred Zodda. He's a healthcare IT expert and IT advisor. And then we also have Azalea's Director of Implementation, Marshall Taylor. And with that, I'm going to go ahead and turn it over to Marshall to get us started.
Thank you, Ellen. So again, hello out there in the webinar world. My name is Marshall Taylor. I'm the Director of Implementation here at Azalea Health. Today, I'd like to walk through what has changed within the EHR market. So kind of a look at then versus now. Starting off, looking back in the day, initially, EHRs were mandated by the government with a focus on federal compliance. I think we all remember the days of MU and MIPS. Still some of that lingers now to today within our quality and regulatory measures. But unfortunately, a lot of vendors missed the opportunity to make these solutions good for the clinical side and truly as an operational asset. They wanted to meet quality and regulatory measures and make sure that those incentives were met for the facilities that were using them. And really, as an industry, I will say, the industry feared the change. We missed an opportunity as an industry to think through problems that we have in hospitals and how EHR can help deliver a solution to those problems. We just missed the mark on that. Instead, communication between physicians and staff suffered and truly became cumbersome. There was more of a focus on the provider entering information in the system instead of truly spending time focusing on the patient and their needs. Also taking a look at the workflow adjustments. The industry told providers how to practice, which, as we all know, providers sometimes practice in different ways. But for vendors, the focus was just on meeting federal compliance and standards over developing a true clinical system of intelligence. No one truly took into account of the provider and their staff and maybe how would they use the system, how do they view information, and biggest of all, how to make it easy for them to use. So those are kind of some of the misses from back in the day, but I will say it's a different story looking forward to now. So now, people look at EHRs as, an opportunity for clinical intelligence and affordability. We have the emergence of software solutions, and they're bringing big box EHR capabilities to smaller hospitals who once really could not afford them, just because they were more complex solutions. So the system is now truly connected with interfaces, combining your LIS, your RIS, MedDispense, all these different things into one place, which helps create a more seamless patient experience and enhances the continuum of care. Also taking a look at customized workflows. I mentioned back in the day, EHRs were telling providers how they had to run, whether it's their practice or whether they were documenting within a hospital. But today, you are able to customize workflows and let the provider practice medicine the way that they want to. Another thing that has come a long way is patient engagement. So, it helps patients stay more connected and remain in control of their healthcare decisions. And to be honest, it's much easier to communicate with a provider and their staff. I can speak on my own terms as well. It's much easier to communicate with my provider these days than it was, even a decade ago. These emerging vendors, in the market, they've focused on building that system of clinical intelligence. And it allows you to still meet regulatory requirements, but also in the end, customize your workflows, promote patient engagement, all at a very affordable price. On the next slide, I'd like to take a look at what we've all been dealing with. What has changed with COVID-19? I know that every provider that I talk to, every physician and their staff, and any staff that works in a facility has seen some shortcomings, when looking at their EHR. But there are some EHRs who are out there who are trying to create solutions to make it better. There's obviously workflow adjustments with COVID-19, and the impacts of that have been difficult. So I think a lot of people have to ask themselves, is your EHR equipped to quickly adjust to the changes? The whole patient experience is completely different now. Patients are coming in, they're triaged differently, and the staff literally had to adapt overnight. This was, 1 week to the next that everything just completely changed. So when you're looking at the staff, what's changed with them? Well, they're having to wear protective gear. Maybe that makes the system, viewing system information harder. They're having to make split-second decisions and need to be able to review the full scope of patient information. So it's important that your EHR is able to do that. There's also still the administrative burdens and requirements that are amplifying burnout with physicians. It concerns me just because the burnout is felt, and I think physicians are already in shortage. So is that just going to amplify the situation? They're spending more time documenting on patients while trying to ensure that they meet these regulatory and quality measures that their facility has to get to. All of this, again, just takes away from time being spent with a patient, and they're just spending more time documenting on a computer, which why a lot of people did not go to med school to do that. They went to med school, and became a physician because they wanted to truly help people and improve healthcare. Another thing, remote work environments, they're difficult to stand up and to operationalize. A lot of vendors have been late to the game. The temporary workaround is just that. It's temporary. You've got to make sure that your EHR truly has a long-term plan, and ensuring that vendors are able to work towards a complete cloud integrated system. You have to ask yourself if your EHR is doing that or is already there. On the next slide. So again, going back to the traditional EHR and kind of taking a dive in there a little more in depth. So this truly is the big box approach. Back in the day, you only had a couple of huge EHRs that essentially told, each facility that they were going to be implementing in, this is the way that we do it, and this is the way that you have to follow. It was truly designed for compliance and billing. And the focus is it's on dropping claims, it's on meeting quality measures. It's not necessarily on patients and clinical workflows. It is a one-size-fits-all approach. But as you all know, a 200-bed facility in a large urban area, or even bigger than that, is going to have different needs than a 25-bed facility in a rural area. You need to ensure that your EHR understands that, and that the solution is able to, appeal to both simply. That's able to be tailored to both. So all functionality, it's provided by a single solution traditionally. While it is fully integrated, it's kind of a jack of all trades, master of none, if I can kind of use the phrase. The big box solutions, they're clunky, they're semi-functional with their LIS, their RIS, their med dispense. It never does it really great, and I often hear that feedback from clients coming over to Azalea. Taking a look at coding over configuration, EHRs in the past understood the requirements of what the system needed, and they knew at the time they had to expand their capabilities. So, if a provider comes in and says, "Hey, I need this information to be able to view it," a lot of big box EHRs back in the day would come in and say, "Okay, well, I'm going to add that information right here for you," but maybe they added it to a page that only the registration staff used, not the actual physician. So, but it was maybe easier to code that way. So they weren't necessarily taking into account what the workflow was of the physician staff, and so on. Whereas today, you have to ask yourself, is my EHR taking into consideration how I practice medicine? The final item on this one, if you look at your support models, traditionally it was mainly there to service billing. There weren't a lot of resources for clinical staff when they had questions. Today, the model has to be that you've got to be able to support the entire facility, not just your billing staff, but your clinical staff as well. That's just a huge part of it. And then on to the next slide, taking a look at the modern EHR. Today's EHR, it's designed to create a system of clinical intelligence. Yes, of course, it still has the core billing and administrative functions, but those functions should truly be invisible to the clinician. The clinician should be able to come in, focus more time on the patient, and the system should be able to, it should be easy to document within that system so the provider's not having to spend tons of time back on their computer. It leverages lessons, I will say, learned from other industries, probably taking more of an app approach. And again, that's just a user-friendly piece. It's easy to navigate, it's easy for the staff to use, easy to view information. Facilities data exchange, it unlocks the liquidity of a provider's data assets. So clinics can talk to hospitals, hospitals can talk to clinics. Again, this ensures that if I go to my PCP and then I have to go to the hospital, that all of my patient information is still easily accessible and it continues the full continuum of care. Finally, it provides native extensions, such as telehealth and patient portal functionality to truly enhance the engagement. So patients feel more empowered with their healthcare and the ability to view it more freely. They're able to speak with providers and staff at just the click of a button, which has been a huge advancement, especially when you talk about patient engagement. So it's just a lot of capabilities have been expanded beyond what they used to be. And finally, on to slide 7. So just to summarize what I've discussed here about kind of the traditional EHR versus then and now, one size does not fit all. Each organization is unique in the way that they have to operate, and your solution has to reflect that. EHRs, I will say, have come a long way as an industry over the past several decades, but we have to continue working to grow and change while meeting our clients' needs. But you need to ensure you're working with an EHR who is willing to listen to you and your feedback. Thank you so much. I'm now going to pass it over to Fred to discuss frameworks on assessing the current EHR.
If we could change the slide. So I want to welcome everybody. Hope you're all doing pretty well in these unusual times. How to assess the EHR, or by old terminology, healthcare information system, if you want to merge in some of the financial implications along with the clinical, without being trite about this, and you all probably know this, but this is a really big deal. And so the reason I say that is the commitment of time and people. And when I say people, we're talking from the administrative suite down to the users. is very critical in terms of what you do up front, so that you don't end up with something that gives everybody a pretty big hair day when you're all done and have implemented this. You know, depending who you buy from and what you buy, this could be either the largest capital expense you have, other than putting up a new building or a new wing, and or one of the larger ongoing operational expenses that you could have. And, you know, it really could affect how you conduct your operations, how you deliver care, how you manage your finances. So, you know, what I usually tell my clients starting out with this is, number one, don't think just tactically. And what I mean by that is, you know, if you're using system XYZ and using these 10 applications, don't view this merely as a replacement of those applications. Step back for a second, think strategically, and where are you going over the next 2 to 3 years in terms of services provided, what your continuum looks like, you know, how you're going to manage your organization, and include those features or applications in your search. And what's kind of important about that is you don't come out of this where 2 years down the road, maybe you're having to go back and ask for more money. You know, that's going to happen anyway, because we're in a dynamic industry. Healthcare changes, regulations change, and technology changes. So, you know, no matter how hard you plan, there are going to be things you hadn't covered because they didn't exist at that point in time. But you should step back and try to think strategically about it, because to think purely in replacement terms, you may end up with a vendor that can't do the things that you're going to need 3 years down the road. Secondly, you've got the cost implications of having to go back to your board and asking for more money when you might have been able to account for that up front in an organized way as a phase 2 or 3 proposition. So, you know, what I'm going to talk about here is a method basically of accommodating those things, and also that will help you get the job done. And what I mean by that, I've seen many instances where an organization will start the process of doing a search, and then it just drags out, and the people participating eventually start losing interest or not paying as close attention to things and doing their due diligence, or in some cases, it just loses steam and you end up making no decision. So if we could go to the next slide, a couple of things that you need up front to make this evaluation successful. You need a methodology, something that gives you a discipline, a timeline, a standardized way of looking at things. So across your continuum of care, well, everybody brings their particular expertise and experience to the table. They're also making sure they all look at things in a similar mode and account for similar things, so that when you compare vendors side by side, you have some baseline of comparison. You want to build objectivity into your process, and the methodology helps you do that, okay? And the methodology that we're going to talk about a little bit helps you develop data, okay? You don't necessarily make the decision just based on one single piece of data, but it could point you in a direction that you start looking under the covers more. And so we're going to talk about some data points. You want to set realistic expectations with your participants. And the most realistic one starting out is, there is no perfect solution out there. Every vendor's got some issues. Every vendor's got some places that are a little stronger, some places that, you know, an application might not be as robust. Every vendor has some clients that are less than satisfied. And the key with that is, why are they not satisfied? Yeah, maybe the software could have been in the implementation, could have been support from administration, could have been turnover in departments, could have been a lot of different things. So don't expect to find a vendor where every one of the clients is totally satisfied. And even within their best clients, there might be a department or two that for a variety of different reasons may be less than satisfied. You want to encourage user buy-in, okay? And the only way you do that is to get them involved. And typically in these processes, you can get more people involved early, and it starts dwindling down a little bit as you move from, let's say, demos, vendor demonstrations, reference checks, site visits. You can't take 50 people on a site visit, and then contract negotiations. But along the way, as many people as you can keep involved and let them hear what other departments' issues are, okay, helps you get the buy-in, so you avoid that moment, after selecting a system when someone says, who picked this? How'd we end up with this? Because again, coming back to there's no perfect solution, it's important that every department hear the other department's issues. So if their number one system doesn't get picked, they'll understand why, okay? And then you want to look for as much integration as possible. All right, depending on the size of your hospital, I mean, the smaller you are, the more hats a person might have to wear in terms of where he or she interjects themselves into using the system. So if I give you a user definition of integration, this is not very techie oriented. Number one, the system's got a similar look and feel wherever you access it across the continuum of care. So a user doesn't feel like they're having to learn 2 or 3 systems because they kind of move around at different points in time. Number two, wherever you look up a piece of information on the system, real time, it's the same every place. You're not waiting for something to be updated, and it floats upstream and downstream. So you make a change in billing because they had the incorrect financial class. The next time the patient registers, it's going to show the correct financial class. And whenever you want to access data, let's say create a report, you can access everything using the report writer. And that's just a very simplified but user-oriented definition of integration. So if we talk about the first step, okay, it's defining who's going to be involved, define your decision makers. And there's multiple levels of this. There's a selection committee, and I've seen everything from very small ones of 5 or 6 people, which I don't advocate, to, believe it or not, one place that had 40 people on the selection committee. There's no absolute number for this, but somewhere between 10 to 15 people probably is optimal, again, depending on the size of your continuum of care, so that you get all the major players involved in making the decision, as you start eliminating vendors. But beyond that, within the process itself, you have decision makers, beyond that committee. You got people in the departments, the managers, that along the way, you want them to feel like they're playing a role in this decision. One of the things I like to see in a selection process is that it's set up in a way also that the departments are interacting with each other the same way they're going to have to interact when you're implementing a system. So while you're doing, your main goal is to come away selecting a new HR, behind the scenes, you're also beginning to set the stage for successful implementation. And where I go with this, so, certain applications, when you're building them, okay, affect what happens in other applications. That same thing goes on in the decision-making process for which system you're going to select. So you want to get those related departments talking to each other and understanding, how the choice is going to affect them. You want to create some checklists, okay? This is number one, the place where you start creating data points. So you create a checklist for the demos, all right, that helps people step through the demo and look under the covers in a way that they may not have done, before. You don't want people leaving and somebody says, what'd you think? And they said, boy, it was pretty nice. I really liked it. You need some more in-depth, okay, answers that are not just the functionality answers too, that encompass things like, how user-friendly was it? What did the integration look like? What was the reporting act like, both in the standard reports, which often give you a lot of flexibility, and also in the customized reports. How easy is it for them to access data, to find what they're looking for? What's the implementation process and the support processes like? Even though these are application demos, you want to have sessions that give you a look at the implementation and support processes for that vendor. You net it out, how much easier does it make them do their job? Or does it make doing their job more difficult? And how flexible is the system? We were talking earlier about the flexibility to change and make the system adapt to your workflows. If you want to change what some of the templates look like or create your own templates, how easy is it for you to do that? Do you have to be a nuclear physicist, or can a normal person deal with that? We like to generate at the beginning of the process, even before the demos, a request for information. All right. Some of the things you want to capture in that: detailed, and I mean detailed 7-year costs that also take a peek at those strategic things we were talking about earlier. And when I say detailed, I mean full boat. I mean, 7-year operational costs, year by year, including price increases, including subscriptions, including transaction costs, if there are transaction costs for things like electronic billing. What does the vendor's client base look like? By bed size, by applications that clients are using. How many clients are using each of those applications? What do their references look like? And have them give you a list of 10 to 15 references with all the references that are in your state, and what applications are they running at that point in time. Somebody might say, well, the vendor's giving us their references. They're only going to give us their good references. Number one, I'll talk about this in a second, there's nothing wrong with that. But number two, you'd be surprised when you call some of the references that you're given, that they're not all good references, especially when you require them to show all the references in your state. But coming back to the good references, you actually want to speak to their good or great references, and then be able to ask them the question, what'd you do to become a great reference? Did you have to throw 100 bodies at it? Okay, which you might not be able to afford, or was it done through specific types of training, specific types of support, that sort of thing. You really want to understand with these vendors, what do you have to do to become great? In terms of the demos, which is really the next step after the request for information, you want to structure it to a certain amount, okay, but not totally. Okay, first of all, if you've been using a vendor for a long time, and there are people that have been on their vendor for 20 years, some for 10 years, okay, a lot of times that system has really changed, but you've become so set in your ways that you really don't even know what the current system looks like. You've had turnover, people have not had a thorough formal retraining, it's been a lot of on-the-job training. Okay, so you want to start the demos with what I call the patient cycle demo. And we usually ask anybody that's going to attend any demo to attend this patient cycle demo. Some vendors call it a day in the life. I just call it the patient cycle demo, where you take a look at what your continuum of care is, and you bring someone into that continuum for this visit in a non-acute setting, whether it be home health, whether it be in a clinic, that sort of thing. And you show how in that environment, they can see everything about that patient's record, that the information is tied to the patient, not to the episode. So you don't really have to know when the patient has been there before. You basically just have to know that you have the right patient, and you can look up anything about that patient. And you want to see the vendor step that patient and move that patient around the continuum of care. Maybe order some tests and things, and then decide to admit the patient, and so show that the results follow the patient. Anyway, you move the patient around your continuum of care. That enables you to see the integration, that gives everybody that's going to attend any demo a look at the big picture. How does their piece fit into this? Okay, because remember, somebody's going to have to compromise, because there is no perfect solution. It doesn't mean that the departments, if you want to get back to, your high school days, is going to have to take a C or a D application necessarily, but they may end up with a B plus as opposed to the A minus or A plus, just because the overall impact of the vendor they're picking is A or A plus for the organization. And as part of this process, you want to use the demos to develop what I call the top 10 list, where you have a different top 10 list for each department, and maybe sometimes even within that department. Nursing could have multiple top 10 lists because there's different levels of nursing spread throughout your continuum, okay? And basically what you're looking for is the 10 to 20 items that they feel are most critical for them to be able to do their job the right way, to run the operation the right way, and to deliver care the appropriate way. And you go into the demos with those initial top 10 lists. You might say, well, how do we create a top 10 list? Well, what do you like the most about your current system? And what do you hate the most about your current system? And start constructing your top 10 list from that. But then in particular, if you've been on your system a long time, or if you haven't looked at systems in a long time, and a long time is an interesting term, because in where I come from, 2 years could be a lifetime in terms of the product development cycle for a vendor. The vendor can be completely different over a 2-year time period. So if it's longer than 2 years since you've seen a system, I don't want to say you don't have a clue, but I'm saying it's worth some due diligence to go back and look at that vendor again. And the other thing I like about the top 10, about the patient cycle demo, is it's everybody's first look at the system, okay? I tell people, don't use the checklist, all right, in that patient cycle demo. Step back, try to take it all in, make some notes, but it's the equivalent of the first time you go to buy a house or rent an apartment. It's your first peek at it, okay? And you're sort of just getting a global sense that might help you make some decisions down the road. When you go back to look at that house the second time, you start noticing things you didn't notice the first time. But the fact that you went there the first time helps you start spotting those things more quickly. So you go into the demos with this initial top 10 list, and you use the demos to refine it. You use the demos to say, oh, everybody can do this now. It's an automatic. I don't want to put that there. That's like, giving away a draft choice. And you see things that you didn't realize were out there, and you add them to your top 10 list. And when you get into your departmental applications, then you use the checklist, okay, that you've designed for that to score the vendor, not just on the functionality, but to score the vendor on the other undercover things like the user friendliness, the degree of integration, the reporting capabilities, the flexibility of the system. And you generate a data point. So you come out of the demos with those 2 data points because you score the checklists, you've got the RFI data. But then what you do is after the demos, you get everybody that's attended any demo together in a room, or these days in a Zoom session, okay? And you start running through each of the vendors. What'd you like? What'd you dislike about that vendor? And somebody takes notes. If you're in a room, what I like to do is put big paper charts on the walls as you write down these things, so people, as you're talking, can look around the room and see what everybody else felt about this vendor. And let's say you looked at 4 vendors and you're going to eliminate 1 or 2. When you come to making that decision at the end of this session, okay, everybody has a good sense of why that decision went the way it did, because they've heard everybody else's pluses and minuses. And then you take a little poll at the end of that and say, okay, we're going to get together with the committee, the selection committee that's going to make the final decision. But what's your thoughts? What vendors do you think it's worthwhile continuing to investigate? Continuing to use your valuable time to investigate. And in some cases, you could look at more than 2 vendors, keep 3 vendors in if that's the case. And that's how you also make sure that the user requirements align by everybody hearing everybody else's issues and hearing what their thoughts are on it. When you finish that, whatever vendors you kept in the process, you go back to that original list that the vendors gave you in the RFI, and you start calling references, and it's peer-to-peer. Okay, lab calls lab at a hospital, registration calls registration, ED calls ED. All right, and they go through a similar checklist to the demos where they reconfirm some things from the demos, but now it's not the vendor telling you it, it's your peer explaining it. And at the end of that checklist is your top 10 list. You notice I haven't mentioned an RFP in this. That's the RFP, where instead of having a salesperson fill out and say, we can do this, your peer at each department in a customized way goes through your top 10 list with you and tells you whether the system can do it, and also gives you the latitude to go beyond the yes or no response and say, well, you don't sound too excited about this. And they say, oh, well, it's really cumbersome. It's not easy to do, okay? So you get a context to their answer. So that's the fourth data point, because you score these checklists, and same thing at the end of that, when you have the scores, you get everybody that did the reference checks in the room and you debrief them. So everybody hears everybody's issues, okay? And then you bring it to the committee after that group votes, and the committee decides, okay, who do we want our 2 finalists to be, okay? And you take a small team and you go out on site visits, ideally to a site, all right, that's running everything that you're going to buy, so you could see it in one integrated manner. That doesn't always happen, okay? Sometimes there's a one-off. We have to go someplace for one department, but you try to go to one site, ideally within a 2-hour car ride, but that's not always possible either. And you also want to bring in the vendors again. While you've had an initial look at implementation and support, okay, during the demos, okay, and during the demos, we like all the managers to attend that initial session. Now, when you're down to 2 vendors, you bring them back in for a detailed, 3-4 hour discussion of the implementation process. Where do you need more resources? Okay, how often do they come on site? What's their support process like? Okay, how often do they have new releases? You certainly don't want to be doing a new release every month. Okay, and things you're going to be looking for in the reference checks, and in the site visit, your evaluation of the support itself, the software itself, the functionality of it, the ease of use, the same things you looked at in the demos, but now you're going to score in more detail the support processes, the implementation process, the system responsiveness, the response time from the second you hit that key, how quickly do things change, all right? The technical capabilities of the system. And again, you've scored your top 10 lists now, both in the reference checks and the site visits. So you got a pretty realistic idea of the capabilities of the system in each department. Okay, if we could go to the negotiation slide. Okay, so I like to have the negotiation with 2 vendors, even if one seems overwhelmingly the favorite. Okay, if nothing else, you want to keep a second vendor in people's mind or in the vendor's mind as a stalking horse, so it helps you in the negotiation. But in that negotiation, you're looking for protections for yourself. What are their regulatory standards? What's their response to regulations? Do you have to pay more for that? Okay. What are their support standards? What happens if they don't meet those support standards? What happens if they don't deliver regulatory requirements on time? What are the hidden costs? Hopefully, we've discovered all of them during the RFI, and as we've gone through this process, talking to their references, and that's good questions that we always ask the references, okay? But we're going to continuously, even throughout the process and in the negotiations, keep refining those costs to make sure we've covered everything. Costs you might not think of sometimes, so you're going to have interfaces. The vendors give you their side, of the interface, but what about the third party that they're interfacing to? What's the cost from that vendor's perspective? So you want to make sure you include dollars for the third-party side of interfaces. Are there any hidden maintenance fees, hardware costs? A lot of times you're given a hardware cost up front, okay? And if you don't read the fine print, you don't notice that it's the first 3 years or 4 years. Well, if you're doing a 7-year contract, what happens in year 5, 6, and 7? What training do they provide? But to me, beyond that, how do they determine if that training's been successful? Some kind of a test? And what do they do if you say to them, we need to do this again? Okay, they're going to charge you. How do they cap their annual price increases or subscription costs? Who are the third-party vendors? Anything they've proposed, I want to know, is it their application or is it a third-party application? And, is the cost for that third party included? And when you go to contract, are those third-party vendors included in the main vendor, the EHR vendor's contract, or do you have to get a separate contract for each of those vendors? And as a part of this negotiation, and we've been doing this ongoing, but one final time, you want to detail out all the interfaces that are needed, all the conversions that are needed with some sort of, at least minimal spec for each of those, so there's no surprise, okay, when they deliver the interface or the conversion. And are you going to do any archiving? Not every vendor can convert every data element for a piece of information in your current system, so you might need to do some archiving. So that, in a nutshell, is a really 30,000-foot look at what you might have to do for a successful evaluation. You need to build in objectivity with that methodology, realistic expectations. There's no perfect system. Involve as many people as you can in the process so you get user buy-in. I often joke that this is the easy part. Implementing the system is the harder part. And so if you need that user buy-in to help spawn a successful implementation, what's the degree of integration that's there, and make sure you've got really detailed pricing so there's no surprises, okay, and you minimize having to go back and ask for more money down the road. I think I'll turn it back to Ellen at this point. Thank you, everybody, for your time, by the way.
Thank you, Fred, and thank you, Marshall. This was a very insightful presentation. So at this time, we're going to go ahead and conclude today's webinar. This presentation has been recorded, and we will have it available for you on demand, so you can listen to it again or share with any of your peers. On behalf of Azalea Health and our presenters, thank you for joining us, and have a great rest of your day. Bye-bye.